Welcome. I'm Pamela Collins, Director of the Johns Hopkins Center for Global Mental Health. Our goal as a center is to harness and translate global innovation through meaningful partnership to support the mental health of communities around the world. And thank you for joining today's discussion. As a center, we have been thinking about the question of care for mental health, and we're asking, who provides care? What is that care? And what care do people want and need in communities around the world? And to that end, we are today launching a webinar series. And our first speaker of the series, who I'm delighted to introduce, is Lara Gregorio. With 25 years of experience in the behavioral health field, Lara Gregorio is a licensed clinical social worker and a recognized leader in community building, capacity development, and innovative program design. Lara's work has spanned diverse clinical, policy, and technological spaces, united by her passion for empowering underserved populations and building resilient, connected communities. Lara's expertise lies in blending evidence-based practices with scalable, technology-driven solutions to address mental health challenges. And as the founder of 4C Mental Health Solutions, Lara leads efforts to provide online psychoeducational classes and peer-supported communities that make high-quality, evidence-based mental health tools accessible worldwide. So I am really delighted to have Lara with us today to kick off this conversation online. And what we'll do is I'm going to give the floor to Lara to take us through some introductory PowerPoints and to set the stage for the work that she's been doing. After that, we'll have a bit of a dialogue with some questions and back and forth conversation, and we'll invite you to please begin asking questions. We'd love to hear from you as well, and we'll save some time for a lot of interaction with our participants here in the audience. So with that, Lara, I turn the floor over to you.
Thank you so much. I'm so pleased to be here. And thank you all so much for having me. Get the slides up here. Welcome, everybody. I am going to make two quick little caveats at the beginning. One being, can do that. Thank you. One being that it is 6 o'clock in the morning for me, so bear with me as I may take a few sips of coffee here. And secondly, for those of you coming from the research world or from academia, I'm not a researcher, so the slides are going to be very much almost through a program lens. I build, as Pamela mentioned, I build clinical programs. So you will sort of see that coming forward so much more than sort of the pure research data. So please be gentle with me if you're coming from academia. And you can advance the slide, please. So this topic series is on who is the provider. And as the very first speaker in this series, I kind of want to completely challenge the concept that there is a separate role of provider and patient or consumer. We know that there's an enormous global mental health workforce shortage, but there's another resource we often don't measure very much, and that is the helping capacity that's already present within communities. And these are everyday people, friends, siblings, coworkers, students, neighbors. And I would actually even argue that, we often think in mental health that the frontline workers are the primary care docs, the clinicians, but often the frontline workers are just the people around others in their day-to-day lives. They're the ones who notice first when something is off. They're the ones that someone's most likely to turn to first. So by the time somebody actually gets to a provider, often things have already escalated. And so really this idea of being able to expand that helping capacity within those larger communities is something we should be looking at as we're looking at new models of care. One of the trainings that I provide, and I'll get into this in a few minutes, is a community mental health worker training program online. This past fall, in about the course of about 60 days, I had 7,000 applicants to that program. And of those, I asked a series of questions within that application process. And one of the questions was, around previous experience. Almost 43% of those participants out of those over 7,000 applicants stated that they are already providing informal support to those around them and that they have no previous training and no skills. So in many ways, the program here and the challenge for all of us isn't about creating larger capacity and more clinicians. It's about the training for the people who are already helping and don't have the skills. And the further question is, what if we equipped natural helpers in our community with evidence-based skills? Because the most scalable mental health workforce may not be clinicians. It might be the helping capacity that's already present within those communities. And the example there on the slide is a youth mentorship program that we've been running in Namibia. So you can see those are actually the kids that have been trained to be mentors, peer mentors within their local community in northern Namibia. You can advance the slide, please. When we zoom out and really look at the challenges, we're actually facing two overlapping crises. There's the global mental health workforce shortage, and then we also have this epidemic of loneliness and despair. I would argue that the problem here is also the solution. We have an epidemic of people needing a sense of purpose, needing some belonging, and we will never have enough providers to go around. But if you equip those people who need a sense of purpose, you sort of solve both sides of this problem. And again, you can advance the slide. So 4C Mental Health is really attempting to challenge this, to attack this problem. It was designed to bring these various different elements together by providing practical evidence-based coping skills and emotional resilience education in an online format. The platform is not designed as a clinical intervention necessarily, or not even really peer-to-peer support. It's fundamentally an education platform focused on mental health literacy and skill building. And this is important because instead of asking communities to identify who needs treatment, we instead start by teaching practical mental health skills to anyone who wants to learn. And these are skills like emotional regulation, distress tolerance, recognizing warning signs, supportive communication. People learn how to support themselves, how to support others. And we intentionally keep the delivery easy, accessible, very short lessons, reflection prompts, opportunities for social learning. The psychoeducation courses across the platform are both for personal as well as professional growth or development. And I'd actually argue in this specific model, personal growth is actually a bit of a misnomer because all of the lessons, as you can see here, include reflection prompts, discussions, and there's something incredibly transformative about having cross-cultural conversations about mental health because people feel seen and heard and understood sometimes in ways that maybe shame or stigma might block within their local communities. So it's a very, very powerful opportunity for bringing people together to have some of these conversations. You can advance the slide again. Thank you. I really began thinking about community-based models like this by studying models like 12-step models like AA or the Clubhouse model. The healing elements inherent in each of these are that they're grounded in evidence-based practice and skill building, but also that everyone has a role or becomes engaged in some way in service. And I would say probably the most important part, and maybe I'm biased, but one of the most important parts I think is that there's no hierarchy. I'm a firm believer that there is no hierarchy in healing. Everyone has the capacity, and actually everyone is to some extent both a provider and a patient. It just depends on the moment. So for this reason, 4C really believes in two different doors to this model. Both people can join in order to learn skills for themselves, but they can also join because they want to learn skills to help others. And then once inside the model, they have access to both. So everybody has access both to learn skills for themselves and learn skills for others. And what happens is that this creates a continuous participation loop rather than something that becomes just a one-time intervention. And if you think about traditional models of care, people wait until there's an issue, they get support, and then they leave when they feel better. And there isn't this continuous engagement that is ongoing. And I think there's just a very powerful opportunity to think about what does that look like when people remain engaged once they're better. You can advance the slide again. There are a few underlying ideas behind this model. The first being that evidence-based skills are teachable. Skills from CBT, DBT, emotional regulation can be taught outside of clinical settings. In fact, you can go to a bookstore and you can buy a book with CBT interventions. There's usually worksheets. You can do them on your own. But people know, and there's a lot of research to suggest that individual sort of self-help programs without the accountability and peer support blended in tend to have pretty low long-term engagement. And so really you have to bring these different elements together. So secondly, helping others is one of the strongest drivers of engagement. And further, it tends to also improve outcomes. So research on pro-social behavior shows that helping others increases dopamine, oxytocin, sense of purpose. And honestly, these are some of the things we don't typically include when we have a traditional model where there's sort of this hierarchy. Oh, sorry, not yet. Thank you. when there's a hierarchy of a provider and then a patient or a consumer, we kind of forget the part that everybody has this opportunity to give back and gain that sense of purpose, which we know to be one of the most important elements in healing, and that sense of belonging and connection, which is a social determinant of health that's often just not included in traditional clinical settings other than encouraging people to volunteer or get involved in their community. Right. And so really integrating this fully into the model, I believe, is incredibly important. And then finally, the third part here is that everybody has the ability to both be a helper and a healer. We are all both. There's not necessarily a separate provider or a patient. And I've talked about this multiple times now and we'll continue to do so, but it really varies from moment to moment. So somebody who is a provider today may need support tomorrow. And so really being able to have the opportunity to be both is incredibly important within this model. And now you can advance the slide. Thank you. So some really important things and powerful things happen when you remove this hierarchy. First, and maybe most important for this conversation, is that you fundamentally lower the bar for entry, because participation doesn't require diagnosis or disclosure. People can enter as helpers before they even name their own pain. We often see people who are signing up for a friend or to help somebody else, and that can be a much lower barrier than seeking support for somebody else. And all the research, right, on wounded healers demonstrate that most people who go into this field are wounded healers themselves. They've been through their own struggles, and so that's another indication that often this is a really good front door for people who want to go into the field because they've struggled themselves or may struggle again. And then secondly, this transforms episodic care, as I mentioned, into sustained engagement. People stick around, whether they are struggling or not. By coupling help giving with help seeking, it sustains health, and you see prolonged resilience. It builds their own resilience. And you may actually, hopefully we have researchers who want to dive into this more, but I'm curious and I hypothesize that may actually preempt or prevent future episodes, because inactive help seekers actually become active supporters. So people stay regardless of whether they're struggling or not. And then finally, you get a real sense of agency, connection, purpose, self-efficacy, which is another one of those key elements, I think, in this puzzle. that become core parts of the full intervention. Okay, we can advance the slide again. So here's a little snapshot of what this looks like. Our system uses a digital learning environment, and it's really built for participation. So everything, and it's also built for modern day life. So these are not heavy academic lessons. They are bite-sized multimedia lessons. Most lessons are 3 to 5 minutes long. People can pause and return so they can kind of do it as needed. There are guided exercises, peer reflections. There's stories from lived experience told as first-person narratives, practical tools that people can apply immediately. And then there's continuous access anytime. When you think about most sort of peer-to-peer training programs, oftentimes there's a lot of training right up front, and then people are kind of tossed in to do the work, and they don't have ongoing access to those learning materials. And so really being able to have in the palm of your hand access to those tools in any given moment really helps people to be able to continue to access those as they need them. The goal here is not passive education. It's really meant to be active participation and behavior change through practice. All in all, at this point, I have close to 40 different courses plus 5 certificate training programs. And there's new courses that are added every month and new lessons every week, which also really helps to keep people engaged. Each course, each training program or course in total lasts about anywhere between an hour and 12 hours, depending on the program itself. And as I said, each lesson is under 5 minutes. Okay, we can advance the slide. I want to ask everybody, and I know everybody has cameras off, so we can't see each other, but let's pretend we're in a big conference room right now. And I want to ask everybody to raise your hand if you feel like you know, even professionally, quite a few coping skills or evidence-based techniques like reframing. Maybe you've learned them in school or, professionally know them. So raise your hand if you know some coping skills, right? And if you don't, and if a lot of people don't have your hand raised, that's telling right there, we need to learn some more coping skills or professional or different evidence-based interventions. Okay. Now, I want you to keep your hand up if you remember to use these for yourself in a moment when you are overwhelmed emotionally or in a lot of distress. Most people do not, because when we're in a moment of distress, we lose the ability to remember the skills that we already know. All of us do. It doesn't matter. I've been a clinician for 25 years. I know a lot of evidence-based interventions, but when I'm in a moment of distress, I don't necessarily turn to those, right? And I think most of us don't. And we know this, psychologically, we know our logical, rational brain goes offline. But that's where community is so incredibly powerful, because when you're in a community of people who all know these skills and are all learning these skills, we can help each other remember to practice them in a moment of need. And that becomes incredibly powerful. Now, this is a community of over 10,000 help seekers and people who have learned to help others. And all of them have access to exactly the same set of tools. They share resources. Someone may be having a hard day and another member can refer them to a coping skill in the library that they all have access to. They may all be from different cultures, but they share the same language when it comes to these evidence-based interventions. That becomes their common language, right? Okay, you can advance the slide. So let's talk numbers. I'm going to say just fully transparently, this program is about 18 months old, so we are new. It's just me. I have no staff. I have no funding. I have no institutional support. And I have reached over 13,000 members enrolled in the program from over 100 countries, over 300, almost 400,000 interactions. We have engagement. I have engagement largely across sub-Saharan Africa, Southeast Asia, North America. But I will say even further, it's not just the reach, and you can advance the slide, it's the depth and engagement of participation. Sustained engagement is one of the biggest challenges in digital mental health. Some studies consistently actually across the research suggest that only about 10 to 20% of users remain active after a month of usage. What we see instead here is long tail participation. Over 4,300 people have stayed at least 1 month. 2,500 stay 3+ months. 900 stayed 6 months or more. 200 people have stayed over a year. So people stay involved because this experience provides learning, connection, and opportunities to help others. And like I said earlier, even if somebody is coming partly because they want help for themselves, they stay even after that ends because they have an opportunity to give back. That sense of purpose, that sense of belonging, sustains engagement over time. You can advance the slide again. I've had over 4,000 people that have taken the community mental health worker training. Participants who have completed this training have reported increases in confidence in supporting others, increases in knowledge of coping skills, a stronger sense of capability. And these are not just educational outcomes. These represent community capacity building in action in real time, right? You can advance the slide again. And I'll be upfront in saying that most of the data we have currently is observational. This is self-report. This is not controlled research. But I have been gathering data over the last 18 months and looking at some outcomes. And you can see here sort of impacts on resilience. You can see impacts on social connection, purpose, and hope. And I've also been measuring a variety of different measures around constructs for emotional awareness, distress tolerance, emotional regulation, self-efficacy. My goal and my hope moving forward is to be able to really look at the triangulation between engagement, help-seeking behaviors versus help-giving behaviors, and then looking at those models of hope, social connection, resilience, self-efficacy, and how all of these interplay for ongoing sustained health and well-being. Serious plug there for anybody who wants to do some research. I have more data than I know what to do with. So, and it's not my field, so would love support if anybody is interested. And you can advance the slide again. So I think one of the biggest things is the biggest takeaway here is to think about the fact that the challenge here might not be about how do we build capacity among clinicians? How do we find more clinicians? I think I would argue that the challenge is more about how do we activate the community that is already providing helping skills. The motivation is there. I can tell you, in 60 days, I had 7,000 applicants. The people want to learn these skills. It's about providing the access to be able to learn them and then putting them to use in their local communities. And we'll talk about that, I think, in the discussion a little bit as well. But we've seen that happen as well with ripple effects of people who have gone through the training at 4C and then have taken that into their local communities. And I've seen that in many communities, particularly across sub-Saharan Africa. So would love to talk about that further in the discussion. And that is the end of my slides. So happy to discuss further. We've got lots of time for Q&A and happy to move into that section. Thanks so much, everybody.
Let me make sure I'm unmuted. Thank you so much, Laura. That was a wonderful overview of the work you've been doing. And gosh, I have a lot of questions. But I first would like, and I'm sure a lot of people here would like to know a little bit about how you got to this point. Can you take us to the beginning and talk about your journey to developing this and this intervention? And yeah, tell us a little bit of the story.
Yeah, so I'm actually going to go way back to the beginning. So When I first got out of grad school, one of my first jobs, so I'm a licensed clinical social worker, and one of my first jobs, I've over the years have worked in pretty much every frontline capacity clinical role. But early on, I was working, if anyone knows San Francisco, there's a community called the Tenderloin, a neighborhood in San Francisco called the Tenderloin, which is the worst neighborhood in San Francisco. Lots of severe chronic mental illness, very, very heavy substance use, lots of homelessness, marginally housed individuals. And I worked in the community mental health clinic there as an intensive case management therapist. And we just saw a lot of patients and clients that wouldn't come in for appointments. And as a care system, we labeled them treatment resistant. Um, and but I started saying, well, maybe it's just that they don't like what we're offering, right? And so this was years ago. This is going to age me. I went on Craigslist and I got some knitting needles and knitting yarn donated, and I put up some signs around the neighborhood, and I started a knitting circle in the basement of the clinic. And sure enough, all of these women from the neighborhood, largely immigrant women, limited English skills, severe chronic mental illness, who had been isolated in their single room occupancy hotel rooms that the city had put them up in, weren't going to appointments, largely often because either cultural stigma or because they had poor insight. If they didn't think they had an illness, why would they go to meet with a psychiatrist? But they would come to knitting. And so week after week, and I actually didn't know how to knit. So I wasn't even an expert. Here we were going to sit shoulder to shoulder and we were going to learn how to knit together. And I bought all these, this is how long ago this was. I got some VHS tapes and some books, and we sat there shoulder to shoulder, and together we learned how to knit together. They got really good. I didn't. I stayed about the same, but they got really good at knitting. And so after a little while, we stopped talking about knitting and started talking about life. It kind of turned into group therapy. Trust was established. Many of them did start going to appointments. They got on medications, some of them for the very first time. A new group came in. The first group taught the second group how to knit, and there was peer support happening. They started selling their stuff at the local farmers market. So then some economic mobility was happening. And after that, I left clinical work for a while because I thought, we have this model all wrong. There's got to be a better way to do this. And so over the years, I've really thought instead about how do we build from the bottom up? How do we ask what communities actually want and need? And how do we design for that? And so it totally flipped everything on its head for me. How do we learn shoulder to shoulder? How do we take away that hierarchy? How do we say we're all on an equal playing field here? Mental illness does not discriminate. Every single one of us has many of us have been through the same struggles. And so why should one person be the expert and one person not? I think we all have wisdom to share. And so that really was sort of the inspiration that has stuck with me. And then over the years, I've sort of done a variety of different things. About 10 years ago, I got involved in digital mental health delivery as a way to better disseminate evidence-based interventions to people who couldn't have access to them because of geography. And that really began my journey into thinking about how do we use technology as a way to provide better access on demand, and so that was sort of how all of these elements blended together, and then I started this program, like I said, about 18 months ago.
Great, thank you. That's a great story. I love that. I love that you had such a personal experience of really bringing community together, working side by side, and then understanding how that can actually facilitate care and facilitate healing. So our theme, as you know, is about who provides care, and you aptly pointed out that we can all provide care. I have a lot of curiosity about what you're doing and how it's working, and I want to just say, are you learning anything about the kind of people, like who's attracted to providing this kind of support? A lot of us have been involved in working with different kinds of health workers, sometimes lay health workers. And often there's a kind of person who's really interested in this work, who feels committed to taking the time to learn these skills. I'm curious, are you learning anything about who comes to your site, who's interested in doing this? And my second question is, I want to learn more about the community aspect as well, and how you foster that, and what does it entail? Is it yeah? So let me start with first. Who do you think you're drawing, or do you have much information about that? And then we can talk about how the community is fostered.
Have a lot of information about that. So I think one of the things that's been very interesting is that because there's such intense interest and high motivation for learning these skills, as I said, I gathered over 7,000 applicants to my program in just 60 days this past fall. And of those individuals, and I will say that's just for the community mental health worker training. I have another 6,000 that applied for an addiction awareness and intervention training as well, and another 3,000 that applied for the trauma informed care. And all of them completed these fairly lengthy application forms that asked a number of questions, including, what's motivating you to take this training? What do you see as the number one challenge for mental health in your local community? Tons of data on that, which was really interesting. By the way, the answer was depression almost across the board, which I found, probably not super surprising, but I think what in the qualitative responses, and again, I haven't really dug too deeply into this data, but in the qualitative responses, I think one of the things that popped up the most was this idea that, as I mentioned, so many people are already informally providing support and don't feel equipped. And so there's a lot of people who either have friends or family members who are struggling and they just don't know what to say. And so that seemed to be a recurring theme across a lot of this data. And then there's another section of people who are already maybe in social service delivery or community health, and they just don't feel adequately prepared to provide some of the services, particularly around mental health. And so there's also that component of people who are drawn to this work. Interestingly, when I look at demographic data, so I also have a fairly large social media following, not large in terms of influence or status, but there's over 70,000 people that follow 4C Mental Health on social, and I put just daily little evidence-based interventions on there, CBT, DBT techniques, just bite-sized ones on social media. And of that over 70,000 followers, 55% are male, which is really interesting because we tend to not see that when it comes to helping professions. And yet of the people who applied for the trainings, it was 73% female. The other thing is I actually anticipated when I first launched this that it would be a younger cohort, but actually what I'm finding is that I think the median age for the community mental health worker was 38. So it's actually more sort of the workforce age individuals that tend to be applying. I think almost everybody, the vast majority of folks were between the ages of 25 and 50. So that was also really interesting.
Well, that's great. So a very particular group of people who really actually need to feel competent to either provide support to family and friends, or competent in their jobs where they're actually doing this work already. So that's quite interesting. I was going to ask you about gender, and I'm not surprised that you're saying, because this is what we see in public health. It's what we see in many helping kinds of professions like this. So even in a non-professional setting, you're seeing the same gender differences. But it's also quite nice to see that your following is actually quite balanced. So that's an interesting questions to ask about that as well. But tell me about the community piece. You talked about how important the community is. Can you tell us what options for connection do people have in this online community? And then I'm curious also to know about, have you seen evidence of that spilling over into building communities in person that are not part of the virtual community?
Yeah, absolutely. So everything within the community is really designed around a culture of helping one another practice the skills, right? And it's all focused on the skills itself. So this is not a free for all. People don't. This is really about, everything is very focused on the solution rather than the problem. So really focused on how do we crowdsource access to solutions when they're needed. So someone may, for instance, say, my daughter is struggling with bullying. Does anyone know which worksheet would be best? And then people can kind of say, okay, have you tried this one? Here's a link to the worksheet that's in the library. The tools are all searchable, so people can search as well in a moment where they're thinking, okay, I need something that's around academic performance or work stress, and they can pull up tools and exercises there. And then there's a lot of discussion prompts, reflection prompts. I do polls on a regular basis, which are just allowing people to sort of reflect. I do ask pretty regularly questions around sort of how do people talk about mental health in your local community, and people will discuss that. So there's a lot of opportunities for people to share and discuss. So that's been really interesting, and I encourage that on a regular basis because I think that's really important. And then I have a number of people who just sort of pop in every day to wish everybody a good day. Which is, I think, probably does just as much for them, if not more, than it does for the people who are receiving those messages. So I think that's also really interesting. And I know there's probably going to be this question that pops up around safety and moderation and all of that. So I just want to quickly address that as well. This is such a unique community because you have to remember that I have 7,800 people who are actively engaged in the community. And 4,000 of those have taken the community mental health worker training. So the majority have already been trained on recognition and referral. So this is, or not the majority. Yeah, no, the majority have been trained on recognition and referral. And that's just the community mental health worker training, because that's also covered in a number of the other courses and trainings. And everybody who's enrolled in the program are taking courses and training. So they're all learning about recognition and referral. So this is not a traditional peer-to-peer in the sense that it's not a free-for-all sort of open discussion. These are majority help givers, right? So it's a very interesting dynamic in that way. And then you had another question? Sorry.
I was asking, how does this spill out into
local communities?
Yeah, that's right.
Yeah. So it's been interesting because a lot of the people who graduate from the program, from the community mental health worker training, want to go on to do something locally. And so I have been approached by a number of people who want to launch local programs or take the curriculum into their local community, and we've done that in a number of different places. We launched programs just last year in Liberia and in Kenya. Malawi is interested in doing something, and actually we had 3 programs in Kenya. But the one that we are still running right now is a peer mentorship program in Namibia. Actually, that last slide that I showed were some of the peer mentors that graduated from the program in Liberia. And each of these are people who have graduated from my community mental health worker training, and then people who want to go on and do something locally. I have another program that I tend to actually not advertise more broadly, but it's called Ignite Impact, which really teaches people how to launch programs in their local community and how to get something off the ground. I actually incorporate because I'm in the home of Silicon Valley, I incorporate some of the coaching skills and things that business leaders at Google and Facebook and those different companies use in terms of setting metrics and milestones and things like that, benchmarks, to try to move a project or a program forward. So I teach all of those as well when it comes to building local programs. So I educate people on how to launch a local program, and I have people who have gone through that, and then they will launch something. So the program in Namibia was somebody who graduated from the community mental health worker program. She's already the executive director of an NGO in Namibia, and is a recognized leader in her local community, but hadn't done anything around mental health. And so we launched a peer mentorship program together locally there, and she's been having youth run local weekly peer circles and an after-school program that incorporates emotional regulation skills, mentorship, and community leadership activities, as well as some basket weaving skills, back to my knitting circle days. So they've also been working on that. And the goal there was to really tailor it to some of the local challenges. So she did a needs assessment in the local community and was able to identify that some of the community needs around there were gender-based violence, gang involvement, and school dropouts. And so those became the target areas that she's really trying to tackle locally. And so through this program, the aim is to equip young people with the skills to support one another and make healthier life choices. And so that's been an example of how we can kind of take this program then and then tailor it to the local community and launch it there locally. I think we have close to 100 youth enrolled in that program, and this is in northern Namibia. So pretty amazing ripple effect.
Great. I love that example. So I'm going to turn to the questions. We've got a lot of questions in the chat, and I am going to go through and read some of these to you. So first question, could expanding non-clinical providers improve cultural alignment, reduce diagnostic precision? And is that a trade-off that's acceptable? Is it a trade-off, and is that trade-off acceptable?
Interesting. So I would say that this isn't necessarily I wouldn't want to deem this program to be clinical, or there's no diagnosis involved in this. This is more clinical adjacent. I still think that there is a need for providers. I think there still is a need for traditional diagnostic assessments. That is different. This is more that bottom tier before someone even gets to that point. And I think what's happening is that no one's even getting to that point. So if we move upstream and we provide support, the idea is that hopefully the people who do need to be able to be seen by a clinician receive an official diagnosis, remain, really, faithful to the diagnostic precision that still needs to occur, but it doesn't need to occur for everybody who needs it. So this is redistribution of those who are actually needed, and those limited clinicians who are capable of doing a proper diagnostic.
So great. I mean, I think you're emphasizing that this is an educational platform. This is not a clinical diagnostic platform, but with these skills, hopefully we can avert some of the harms that people might otherwise experience.
Absolutely, yeah.
So next question from another participant. You've talked a little bit about this, but how do you adapt for different communities, language, immigration status, the needs of specific sub-demographics?
Yeah, so I am always polling the community, my online community, about what they want. So this is very interactive and bottom up. This is not me deciding what to create. So like I said, there's new lessons every week. There's new courses every month. Those aren't ones that I've come up with. Those are ones that are suggested from the community. Sometimes I'll come up with a list of the top 5 and then they vote. So the next course that will come out will be around spirituality and psychology. That was suggested from the community, and so that is one of the next programs that will be launched. But yes, everything is very community driven, so that it can be reflective of the communities that are being served. And then in those local communities, my hope really is that, like the program in Namibia, people will take this and run with this and then adapt it to the local language. They will adapt it to the local dialects or the cultural need or the community needs in those local regions. I also recognize not everybody has access to technology. So my hope is that this reaches those first tier people, sort of those early adopters in those communities who do have access to technology, with the idea then that it spreads and that ripple effect takes it to those who maybe don't speak English or don't have access to technology.
Another question, can you share about any interactions that you have had with national authorities, Ministry of Health, departments of health in any countries? Are there any kinds of partnerships or talk about any relationships that may be happening or that you've thought about in that sphere?
I have not done a lot of that, only because I have not reached out intentionally myself, only because it's just me. So I don't have the bandwidth. But I have been approached by members of my community who are employed often by ministries of health and have found me and want to do something. So that has come to me actually occasionally. For instance, there is a group in Pakistan that we've been collaborating and working there as a result of somebody who is very active in my community and works with the Ministry of Health.
I mean, I think what you just said is so important, because if your community includes people that are already part of their ministries of health, it's they're the best people, right, to actually decide what's useful.
Well, and that's been happening here in the States as well. So one of the projects that I just launched literally this Monday of this week was somebody in my community who was taking the community mental health worker training. And she works with a district attorney's office public defender's office in Texas, and said, my mental health advocates on my team need this training. This is fabulous. This is she was already taking the training. She said, this is exactly what we need. Can I give this to my mental health advocates? And so we officially launched a partnership to make that available to the team. So oftentimes it's people who are taking the program who say, I want to go and champion this locally. And so it's that organic growth and organic reach. I don't actually often need to do that outreach. I'm hoping it will just grow on its own.
Oh, that's perfect. So here's a question about mental health first aid. Thanks, Laura, for your time. This has been so inspiring. We offer mental health first aid training in the workplace for employees, but it's very episodic. Do you have any thoughts about incorporating the continuous aspect of 4C into the workplace?
Absolutely. Like I just mentioned, that was exactly what others are noticing as well. Mental health first aid was it has been such an amazing, they've had just incredible growth. I think the need there is just, they've really shown what a need there is in being able to equip workforces with all of this type of information. But like you said, it can be very hard to find trainers who can do mental health first aid, to find a location, to find a time. It's still very much something that you have to take time off of work to do. And so I feel like this is almost the next iteration of that, is that this is something that can be done 5 minutes at a time here and there. It can be done from home. It can be done from your phone. It can be done while you're standing in line at the grocery store. And people have ongoing continuous access. I think that's helpful in a couple of different ways. One is that you have ongoing continuous access to the skills and the information that you learned in the program, but you also have ongoing access to burnout prevention and resilience skills for yourself, which I think is one of the most important pieces we often miss. And so that's oftentimes what I think employers and employees are seeking support around. So this does both.
There's a follow-up question to that, which is, as you're working with communities of people in many different contexts, how do you address needs for referral in parts of the world with few formal services? Does this ever come back to you from people that are doing community health worker training or others, like a need for how to get people connected where they need to connect when there are fewer resources?
Yeah, so this came up actually in rural Kenya. I'm working with a physician there, and that entire region doesn't have a single psychiatrist. They don't have a single therapist. They don't have anybody trained. And so actually his response was, we need more community mental health workers, because there will be no other option otherwise. So it's almost like the it's either nothing at all or, so referral is challenging, but even if you can equip the primary care docs with some of the information from the community mental health workers, at least they have more information than they would have otherwise, right? And so that became one of the targets for that particular partnership. I actually worked with him as well to make this he found a local community center where they had some computers, so that he was recruiting people like literally walking around and telling people to come to this place to go to use, because people didn't have access to technology to be able to do the training there.
I think what's interesting is that you're having really hyper local reach in some places, right? Where they're we're literally there. As you're saying, there may be one provider who is coping with needs of a particular community, and this gives people some additional options for how to expand skills and access to skills. I want to turn to another question in the chat. Many adults 55 and older are interested in this work, but may face tech literacy and access barriers. So with an aging population in many countries, any thoughts about how to explore and how to adapt age-friendly delivery modalities?
What's interesting is I said the majority of people were between 35 and 55 or something like that. We actually do have a fairly robust older population, which surprised me. But what we're finding, particularly in communities in countries like the Philippines, there's a lot of people on Facebook that are in that older adult range. And so I think there's a huge opportunity actually for equipping and empowering, like I said, those who become the early adopters who do know technology to then go out to their peers who are older adults and help them to learn the technology and help them have access. And then you're giving them another opportunity to be of service and to have a sense of purpose and a sense of connection and belonging. So that becomes an element that absolutely plays a role in that ripple effect, and also the healing that comes for everybody involved.
That's great. So certainly all older adults are not tech challenged. And where people do feel tech challenged, I think what I'm hearing is one of the solutions could be to find ways of linking those folks with people who do have a bit more savvy around these tools. Amazingly, we are almost at the end of the hour. And I want to just thank everyone for joining us. And before we stop, I want to make sure that, before I rush on, I just want to give enough time to thank you, Laura, for joining us. This has been really fascinating. I think you have touched on something that everybody knows, right? We all know in our hearts, our common sense tells us that all communities have resources to support mental health. I believe that. I think most of us who are on this call believe that. I'm sure that's why we're here. And I love the way that you've actually shown us a couple of things. You've shown us how, number one, a digital platform can actually help to enhance community itself, but also help to disseminate skills for which community members can also benefit, as well as share with others in their networks. So that's great. It's been a pleasure to hear about this. It's been a pleasure to learn what you're learning. And I think a lot of us are probably excited about figuring out how we can do some of the more rigorous learning from the data that you've collected over time and see what treasures lie there as well.
Yeah, thank you.
I would love to pause now and let everyone know that, again, this is the first of our online discussions around who is the provider, and this will continue next month. And on April 8th, we will be joined by Dr. Sumitra Pathari of the Center for Mental Health Law and Policy, who will talk to us about the same question, but from a different perspective. So please stay in touch with us, follow us on LinkedIn, subscribe to the newsletter. You can keep abreast of what's happening here. We'd love to hear from you as well. So once again, thank you very much. There are lots of thanks to you in the chat, Laura. You can't see all of this perhaps, but lots and lots of thank yous and appreciation for the work that you're doing.
Thank you, everybody. You all so much. Thank you for having me. So fabulous.